Welcome back to another exciting episode of the Oncology Brothers. I'm Rahul Gosain and I'm joined by my co host and brother, Rohit Gosain. Our mission remains the same to keep our community oncologists updated in this ever evolving landscape of cancer care. In our ongoing hematology series, we've covered CLL with Dr. Nitin Jain, and today our spotlight is on newly diagnosed multiple myeloma. With all the new approvals and the FDA ODAC meeting on MRD as a surrogate marker, multiple myeloma has been making the news yet again.
With about 35,000 new cases of multiple myeloma every year, as a community hematologist oncologist, we see a good amount of multiple myeloma in our day to day practice. However, the treatment paradigm in this disease site has changed drastically. To help us unpack some of our available treatment options, we are honored to welcome Dr. Caitlin Costello, an associate professor who focuses on myeloma at UC San Diego. Caitlin, thank you so much for joining us.
Rahul, Rohit, thank you so much for having me. I'm delighted to be here with you today, and I'm so grateful for what you're doing for our community oncology partners.
Oh, very kind of you. You're trying to do a very small part. Caitlin, we have a lot to cover. To say the least, we want you to unpack entire myeloma in 15 minutes. Now, focusing on newly diagnosed multiple myeloma, before we get into the treatment paradigm, what is the minimal workup that you do before you start the treatment?
Fantastic. Well, I think it's important to remember that, gosh, it's a decade ago, but the diagnostic criteria for multiple myeloma changed, right? So many of us probably remember the good old crab criteria and looking back and kind of squinting hard and saying, oh, there's a little anemia, and there's a little bone, and there's a little of this. And we were waiting for patients to kind of jump off the cliff, if you will, to where they have end organ disease. They had some kind of permanent bone or kidney disease or something that prompted us to want to start treatment. Well, in 2014, that changed where we're trying to identify specific biomarkers now that will help us understand who are at the highest risk for developing end organ disease in the near future. So that really now drives our diagnostic workup, if you will. So let's start off with basics. I think we all are comfortable ordering our CBC and our CMP, both for the purpose of understanding, is there anemia? What is the renal function? What are the calcium levels? Those are easy for us to obtain and get a good sense of what's cooking kind of under the surface there. So once you've had your basic blood tests, I think the next steps are to make sure that you've really looked at those bones as best as you can. So the gold standard X-ray, the skeletal survey thing is gone, no more. We really are trying to look in 2024 at high technology. How can we look at bones in more clear and sensitive ways? So probably the sensitivity of the X-ray, just X-rays is 60%, which is not good enough. So at a minimum, we recommend that you do a whole body low dose CT scan of the entire skeleton, or if you can get it through your insurance company, it's preferred to do a PET CT. There are whole body MRI options as well, but just do something that's a little bit more advanced than just x rays alone. So now you've looked for anemia, kidney dysfunction, you've looked for the calcium levels, and you've looked for the bones. That'll kind of give you some basics, because presumably that you're doing this because some patient walked in the door and had, someone had found that they had a paraprotein. So you have their SPEP, or you have the serum free light chains, the immunofixation, as kind of all available to you, quantitative immunoglobulins. You want to collect all that data because that is what will ultimately help you understand what this patient's diagnosis is. And then you have your bone marrow biopsy, right? So 10% has been our cutoff all along, to say more than 10% you kind of enter into at least that smoldering range. But now we kind of say, okay, 10 to 59%, we can classify those patients as smoldering. Once you kind of hit that magical 60%, you're now hitting that biomarker that says greater than 60% involvement by clonal plasma cells in the marrow is multiple myeloma. So once you have the bone imaging, the blood test, you can do some urine tests. That's how we torture our patients, is 24-hour urine collections. It's not gone yet. We hope it will be soon. The last thing, please do not forget, is the LDH and the beta 2 microglobulin. Those are two very critical components to evaluating the staging with that revised ISS system.
Caitlin, thank you so much for setting that stage. So now you have that patient in front of you and some of the information you were looking for, be it PET CT, because insurance said yes, or low dose CT. How are you using this information in planning their treatment? Can you walk us through your treatment paradigm and how are you putting in few buckets and what next for you?
Sure. So now we've identified someone and diagnosed them with multiple myeloma. Kind of as part of that in RISS, the Revised International Staging System, we have taken the FISH data from the bone marrow biopsy and really quantified in a very objective way. That's where your beta 2 microglobulin, your LDH, your albumin, and your FISH abnormalities can all be put into a very objective quantification to understand, is this patient high risk or is this patient standard risk? Now, I'll tell you that in 2024, we don't have a great understanding of what we should be doing differently for high risk patients versus standard risk patients. I think all of us think and assume we need to push a little harder for our high risk patients, but to date, not a lot of trials have specifically evaluated that 15%, let's say, of high risk myeloma patients in prospective trials that help us understand we should be doing this differently. So we extrapolate from kind of bigger trials that say, this is what your average myeloma patient, is responding to, and kind of do the best we can. So when I first see a patient, I make some assignments to say you're high risk, you're standard risk, and then we talk about a treatment. I think it's important to understand that myeloma is not a one size fits all, and that is true about your risk stratification, but also about the patient who's sitting in front of you. I think you both know, just like I do, a patient who walks in is very different from the patient who walks in next with newly diagnosed myeloma. They could be 40, they could be 80, they could be high risk, they could be fit, they could be frail. So you really need to tailor your treatment approach based on a lot of those specific characteristics.
Basically, now, since we have established that itself, where we can in fact go aggressive route or transplant eligible versus transplant ineligible, how would you now tailor the treatment once you've decided where this person fits in?
Fantastic. I think historically we have had these patients walk in the front door very symptomatic from their myeloma, and we kind of as a gestalt or a gut reaction immediately assign them as being transplant eligible or transplant ineligible. And I think that should be going away. We all know that performance status can change dramatically once we get
Indeed.
the disease under control. So let that be a dynamic process.
Right.
It may be, let's say that your patient walks in and they are in decent enough shape, they're young enough, they're fit enough, they don't have, many in the way of comorbidities. Let's assume they're going to be transplant eligible. In today, 2024, the answer is quadruplet therapy. We assume these patients are going to probably be eligible for transplant, and that is a whole other discussion. But to get the ball rolling, 4 drugs now with a phase 3 randomized trial comparing to 3 drugs and a phase 2 comparing 4 drugs to 3 drugs have both shown us that the 4 drugs win. So now we are incorporating into our standard len, bortezomib, dex triplet the addition of that CD38 monoclonal antibody with daratumumab specifically, which has been studied so far as in Perseus and Griffin, have shown us that 4 drugs do better, both from overall response rate, depth of response rate, and progression-free survival benefit. So your average person who we think is going to be transplant eligible should all be treated with 4 different drugs now. For patients who don't, however, are not intended to go to transplant, you think they're too sick, they're too ill, then are really the standard of care as it stands today has been based on the Maya study. This was originally designed to compare 3 drugs versus 2 drugs with that addition of daratumumab to that Lendex backbone. Now we know from the SWOG trial, just I guess a decade ago already, that 3 drugs is better than 2. The question is what is the right 3? And these are for our older, frailer patients. And Dara-Lendex has proven to be probably the most practice-changing approach for older, frailer myeloma patients because it's tolerable. These patients can really stay on these therapies for longer periods of time. Now, that's not to say, however, that if you have an older but even somewhat fitter patient, you can probably get quadruplet therapy in there as well. And I do push it a little bit for my older, fitter, and certainly my older, fitter, higher risk patients. I try to see if I can do what we call the old DARA RVD light, where same concept, use the
Right.
4 drugs, but dose escalate to some degree just to improve tolerability and kind of durability of response.
Caitlin, thank you so much. Dialing the clock back, even be it DARA, RVD light, or when we are thinking of using bortezomib, most of us are using it are using it weekly now. There are very few cases for us to consider biweekly dosing, so I think that's important. Coming back to this patient, when you are deciding your quad therapy, who are you picking bortezomib for versus carfilzomib? If you are going to pick carfilzomib, are you getting a baseline echo? If they don't have any cardiac history, what's your paradigm or what's your workup there?
Great question. So again, carfilzomib has been compared to bortezomib in the relapse refractory setting, kind of head to head to prove superiority of it in the relapse setting. But really, it has not been compared in a way that has proven to us that carfilzomib is a better drug. That said, we still are sure that it probably is, right? So many of us have looked at phase two non-randomized trials looking at the combination of DARE, carfilzomib, len, dex, Manhattan, Master. These are different trials that are designed for newly diagnosed upfront patients and seen that carfilzomib can overcome some of those high risk features. So that's where my fork in the road is. So someone with high risk features that is transplant eligible, I will choose carfilzomib. So those are your 17p deleted patients. Those are your 414s, your 1420s, your 1416s, 1Q amplifications. Those are the patients we really want to try and pursue. I do not do echocardiograms across the board for all patients starting out with carfilzomib. If there's something in their history that concerns me, it's never wrong to do. I think the single most important thing when starting carfilzomib for anybody is get that blood pressure under control, because one of the most common things we see is elevation of systemic blood pressure.
And then, Caitlin, we've talked about the induction therapy. We've said, okay, moving forward, if they are transplant eligible or ineligible, even before we get to that, how are you monitoring? Now, MRD is such a hot topic. How are you monitoring their response in your clinic after induction therapy?
So after induction therapy, we're probably just like you. Every month that they come in and they're getting their cycles, we're watching hopefully that M spike continue to fall down, those light chains continue to fall down. So let's say a patient decides to go to transplant as part of our usual typical myeloma work, or I should say transplant evaluation. It is typical to get a bone marrow biopsy both before the start of induction and following the end of induction to kind of get a sense of how much residual disease you have left. Now, MRD, very critical time point to talk about this right now, right? ODAC just met
Yes.
recently and recommended that MRD be a new endpoint for our clinical trials, where many of us have fought for that because I don't think either any of the three of us will be alive and certainly practicing by the time we get overall survival differences in randomized trials. But let's say that we can use MRD as a surrogate endpoint to make assumptions on how successful our treatments will be and to compare trials head to head to some degree. So, MRD, obtaining minimal residual disease negativity, getting to that point is just half of the battle. We think that getting there and maintaining it is likely going to be the most critical part of this. So, many trials now are doing MRD kind of risk, or I should say, adapted responses, where they will say, let's do a bone marrow biopsy and see if the patient has achieved MRD negativity. Continue on our treatment. Let's say that includes transplant and consolidation, maybe some maintenance, and think about some time point later, whether that's 6 months or 12 months, to repeat that MRD assessment to say, okay, we have what we've achieved. We've achieved what we wanted to. Two distinct MRD negative time points, a minimum of 12 months, let's say, apart. Maybe that's a time we can think about backing off a little bit. I don't know that that's ready for prime time now. That's what the clinical trials are looking at. I would even make an argument that I'm not sure MRD is truly ready for prime time for your clinical practice yet. What it tells us is probably more prognostic in value at this time point, but the hope and the expectation is that at some point it will guide our treatment decisions. I just don't think we're there quite yet.
Thanks for covering that because now the patients are reading all this information, especially after all this discussion at ODAC. Now, if a standard risk patient did achieve MRD negativity after completing the induction regimen, would you be inclined to back off the transplant at all or still consider transplant in an MRD negative standard risk patients and proceed with maintenance?
I'm giving
Okay,
the shrug because we don't know, right? We
right.
think that, as I mentioned, getting there is part of the battle, maintaining it is the other part of it. So
Indeed.
you could make the argument to say, how much better could I get if I'm MRD negative prior to transplant? What do I need to go through that transplant process for if I've already achieved my goal? Don't know the answer to that. But I
Mhm.
think at that time point, it's not a wrong discussion to have with the patient to say, we're here. Our treatments so far have achieved the goal we want to. We likely could continue to maintain that goal and we'll need continued assessment to understand if that MRD negativity is durable. But we don't know. And that's what the trials are answering for us now. But it's not a wrong discussion to kind of review the risks and benefits for shared decision making with your patients at that time point.
Thanks for covering that.
Caitlin, actually taking it a step further, we don't know the right answer, and the patient decides to forego transplant. In this particular scenario, what's your maintenance therapy going to look like? For how long? Is it dual? Are you going to drop a few things? What is that conversation like?
So again, I think what we'll do at that point is go back to the original risk of the patient to understand what the relative intensity of the therapy needs to be to maintain the success that you've had that far. So if you have a standard risk patient who was treated with DARA or Len, Velcade, Dex, for example, they get to MRD negativity, they decide they do not want to go to transplant anymore. I think that's a discussion where you can de-escalate and you could think about what is probably driving the most toxicity with that regimen is your bortezomib, right? So you could probably think about getting some amount of cycles done, and maybe we choose 8 cycles to kind of get the bortezomib in there with the four kind of eight, excuse me, 8 total cycles of therapy. Drop the bortezomib at that point. Certainly get rid of the dexamethasone, and think about should I continue on single or doublet at that point. For your average standard risk patient, you probably could get away with just lenalidomide moving forward. For your average high risk patient who decides to forego transplant, much to the chagrin of your transplant doctor, even at MRD negativity, we think that you're going to need continued intense therapy. That probably looks like triplet therapy in my mind. That includes probably the CD38 monoclonal, the proteasome inhibitor, and the IMID. No Dex. I think Dex is what really does the most trouble or adds the most toxicity to our patients and probably does the least in terms of myeloma killing. So for my high risk patient who foregoes transplant, I'm going to want to continue as much of the drug as I can. So if it's 3 drugs, that's where I think about, okay, we want to do 3 drugs. What is the frequency and can we do any dose de-escalations? And no one knows what to do here. If you ask different centers, you're going to get different answers. There are certainly centers out there who continue on with carfilzomib, for example, at twice weekly and carry on 3 weeks in a row, 1 week off. I'm not sure we need to do that for everyone indefinitely. Um, you could follow some of the Forte data that tells us that you need to do, carfilzomib and lenalidomide and do that for a couple of years and then drop the proteasome inhibitor. So I think the short answer to the long question is continue on intensive therapy for our high risk patients, doing the best we can to make it tolerable and durable.
Sticking with the maintenance theme here, so now the patient has undergone, of course, transplant, whether it's a standard risk or high risk. In terms of maintenance therapy, how are you deciding which one to go for, whether it's a standard risk or high risk there?
A lot of the maintenance decision is made based off of the induction regimen and based on the risk of the patient. So, in your average standard
Okay.
risk patient who underwent quadruplet therapy with DARA RVD, had a transplant, remember the Griffin and the Perseus studies both continued DARA and LEN together for a handful of years before dropping the DARA and continuing on LEN. Now, they also did consolidation, which I would argue many of us don't do either. So, the further away we get from the original trial design, in theory, the further away we could get from away from those same successes. So I think it's worth the conversation with these patients to say, this is how it was done, this is what I propose. I think with your standard risk patients, you could get away with LEN maintenance as it was originally done and designed, and maintain CD38 sensitivity, perhaps for first relapse. So you can retreat patients with DARA as an example again. For patients with higher risk disease, who, for example, may have had DARA KRD as their initial induction, these are patients at post transplant. I really like, kind of per the Forte trial, to continue them on with both a proteasome inhibitor and the IMID. There is the best data for proteasome inhibitors and maintenance for our high risk patients than there is with monoclonal antibodies, for example. I think there's meta analyses that are out there that tell us that DARA probably is good enough to overcome some of the high risk features in these patients that you could continue it with the maintenance setting, but the proteasome inhibitor IMID combination is probably a good backbone to continue patients post transplant for maintenance with high risk disease.
Thank you so much for covering that. Now, just a bit of a twist, Caitlin. Can we take the last few minutes to focus on another subset, a patient with renal failure, where we have excluded amyloidosis, and now we have basically confirmed that this renal failure is a result of multiple myeloma? Your take in this particular situation, what do you usually utilize and how do you proceed?
This is what we probably see all the time, especially working in the hospital, right? These patients come in and you want to give them the benefit of the best therapies you can from the get go. So, one of the things I see happen more often than not, which I will try and dissuade people from, using, is kind of like the old school cyborg. I think we have enough data that tells us now that Cytoxan-based regimens are nowhere near as good as what we know the IMiDs and the proteasome inhibitors do. But those patients really can't get a lot of IMiDs from the get-go. They come in the hospital, you can't get the drug in the hospital. And so I think what I like to do for these patients is start them on the monoclonal antibody, bortezomib, and dexamethasone from the get-go. You can, and the key is that you do that urgently. Time is kidney, right? So the more time that passes, the more that kidney is getting damaged by those light chains, for example. And so if you can start those patients on at least those combinations of three drugs, perhaps when their renal function improves, you can start adding in the lenalidomide as an example at low dose, depending on where the renal function plateaus or hopefully normalizes back at the full dose you would normally do. But my approach is always to try and intervene as quickly as I can. And that DARA bortezomib dex combination is a really easy place to start, probably for all comers.
Indeed. Caitlin, we've covered a lot here. Before we close, any last thoughts for us in community settings managing the multiple myeloma patients?
I think a couple tips. One is please don't continue the Dex indefinitely. Right? We know that the never ending Dex treatment is something that our patients hate the most, and I think we can cause the most trouble with. So, there's data from our older, frailer patients that if we can start them off on Dara-Len Dex and drop the Dex just after 8 weeks, we're not going to lose that response. So don't be afraid to stop the Dex. Um, Please don't forget to send some of the biomarkers we talked about, the LDH and the beta 2. It's very helpful to understand kind of risk assessment. Don't forget your prophylaxis. These are patients, remember, who are at high risk for DVT or thromboembolic events, and certainly for HSV and VZV. So don't forget that those proteasome inhibitors and the monoclonal antibodies all need acyclovir, for example.
Couldn't agree more. Thank you so much for those tips. Those are extremely important. Caitlin, thank you so much for taking the time to go over your paradigm in treating newly diagnosed multiple myeloma. For our listeners, let us go over a quick recap.
In this ever changing space of multiple myeloma, be it new drug approvals or role of MRD, we had a chance to put this all together in this episode with Dr. Caitlin Costello, a myeloma specialist from UC San Diego.
Do we have enough data to pick one quad therapy over the other? What about a perfect maintenance strategy? Well, there are a lot of nuances to be appreciated when treating a patient with multiple myeloma. In our conversation, we have covered treatment options for both patients eligible and ineligible for transplant. Keep listening to stay updated on the latest in hematology oncology. We are your hosts, Oncology Brothers.